And we're back. We have Justin Martino. Justin, this is your first time on. For people that aren't familiar with you, can you tell us who you are?
Yeah, so I'm a Duke outpatient ortho PT. I have about a year and a half experience right now in clinical practice. Before then, I graduated from High Point DPT, where I there had a lot of good influences, sort of allowing me a safe space to begin as an early career researcher. A lot of the stuff that I'm now pushing out, I was working on in PT school. But what I'd say really sparked me with research was earlier as a psych major at Wake Forest, where I really fell in love with research and trying to use it to be as honest as possible, even if it was a harsh truth, I would say. The department professors were really big there on being anti-replication crisis. And I think a lot of that mentality really transferred over me. And I don't even know why, honestly, but I really latched on to the idea of research. Wasn't really too exposed to it in high school, I guess. You just read textbooks and you don't really understand how anything gets there, how it's done in the first place. But yeah, now in my free time when I'm not in clinic, I'm trying to either probably just answer questions that really interest me, or try to progress the field from a critical thinking lens, I would say, or at least the lens that I see it through, right?
And the reason we're chatting today is based on this new editorial that just came out of BJSM, and you were the author. It's called Reframing Exercise for Musculoskeletal Pain Relief, and the components and the topics within this editorial is what we're going to dive into. I'll link the paper in the show notes, and it's a short, a little over 1 page read, but I think there's a ton to talk about. So let's just start with, you mentioned this in the beginning of the paper, the editorial, this kind of common narrative around musculoskeletal pain and this idea that a lot of this is driven by someone's inherent weakness. Can you touch on what that common belief or narrative is?
Yeah. So I think a lot of times people come in looking for answers, and it's our job as clinicians to sort of provide them this neatly packaged assessment, or at least that's the way it feels. And I understand that. I feel that pressure too, right? I don't like telling people necessarily that I'm not quite sure, or leaving it slightly in the air, right? Uncertainty isn't comforting for some people. Um, I think it's often this neatly packaged assessment where impairments are causing their symptoms, and we have an entire objective exam sequence to figure out impairments that may or may not have anything to do with what they're coming in for, right? And what I would say is it's similar to the one of the main flaws of imaging, where we're getting a snapshot in time, right? We might see weakness and pain simultaneously, but we have absolutely no idea if that's causation, reverse causation, or just correlation. So I think it's similarly logical for me to think that someone is weaker because they're in pain. That's a really good way to make someone weak. Just make it painful for them, right? So it's a bit of a chicken or the egg question. And I think this is a tiny example of the broader issue of just people saying stuff because it sounds plausible and was once told to them by someone else that they probably respect. And it's all plausible, right? It's not like it doesn't have a clear line of thought.
Yeah, it sounds and seems logical, and this quick messaging, it's easy to latch onto, and like you said, the certainty of it is appealing for both patient and clinician alike.
Yeah.
You mentioned in the paper this kind of parallel currently in the manual therapy space of these kind of pushback on the strongly held notions of certain things in the manual therapy world. Can you touch on what you wrote about?
Yeah. So I think the parallel here is that you're taught a ton of specificity and techniques with these very specific use cases, and then you get into the real world, and you may or may not, but a lot of people then realize this use case isn't necessarily the use case that I once thought it was, and that it was this silver bullet for a C4 hypomobility. I just give it a good mob and then all their neck pain's gone, right? Then if you look into the research on it, it's a lot less specific than you're often taught, right? So I think we're seeing the same thing now with exercise. It's just, I think, coming a little bit later for whatever reason, but I think that the specificity is important for certain things. a lot of performance and maybe injury prevention, you could argue, maybe not with technique, but maybe with loading. But with pain relief, there is not this clear picture that currently the research is showing specificity matters all that much, similar to manual therapy.
How or why do you think we got to this point where PTs, we feel so strongly about this link of specificity or the necessity of specificity with exercise and pain specifically?
Yeah. So I don't necessarily have any research to answer this, but my impression is that people get into this profession to help. We want our treatments to work as much as they can, but then that also means that we're inherently biased to a certain degree. I think a lot of us get into it from a sporting background. The classic PT is someone that was hurt in high school playing high school sports, and then they went to PT themselves and really latched on to the idea of becoming a PT there. So we're automatically, I would say, biased in that regard. Two, exercise works so well for many things. So being evidence-based often does mean this automatic assumption that exercise can fix it, right? And exercise, I'm not saying does not provide any pain relief. It's just, I think we need to reel back on how robust we think this is. And then I think a majority of the profession probably doesn't dig into this specific question enough. I think that you're taught in PT school that ultrasound is placebo, right? And one nuance in particular is that exercise is hard to sham. So we automatically have less ammo against exercise as opposed to something like ultrasound. But then if you do enough digging, you see that exercise has equivalents to these other treatments, even treatments that are often called placebo. One of the things I pointed out in this editorial was that two of the placebo-controlled studies on exercise showed clinical significance or statistical significance at only 5 of 7 time points when compared to detuned ultrasound and shortwave diathermy. So not even plugged in. They were completely unplugged. And the plugged in version is something that people already call placebo. And one of the interesting things is one of the studies that I'm trying to publish right now is a survey of student physical therapists in America asking their impressions of all these different interventions. And one of the funniest things about it is the dichotomy between how they view things like exercise and how they view things like ultrasound, right? And then you read the research and a detuned ultrasound did not or the exercise didn't outperform the detuned ultrasound at 5 of 7 time points. So it's I think that people get into clinic and then start reading research and then have to question things, and whether they actually take it to heart or not is a different question too.
You're already touching on this, but the second kind of section or subsection within your editorial is exercise is valuable, but its effects on MSK pain are modest. This is essentially what you're alluding to, but can you elaborate on the effects that are present in the research in regards to the reality of it not being, in a lot of instances, super robust or extremely significant, and sometimes comparable to these things that you're talking about that are considered quote unquote sham or placebo?
Yeah. Yeah. So one of the things I hit on there is that we know that exercise is one of the most powerful tools that we have for human optimization. It's useful for strength, speed, power, hypertrophy, injury prevention, lifespan, health span, metabolic health, movement associated fear. And that's an important nuance, I would say, to my paper. You see, one of my favorite papers is by Mitch Gibbs, and it showed that doing deadlifts specifically does help with fear of hinging movements and doing deadlifts, right? So there are some caveats to my paper and even my beliefs and how it might be presented in that roughly 1,000-word paper. And all those things can be true, but it doesn't mean that it's equally as powerful a tool for pain relief. I think there's plenty of clinicians and researchers who rightfully champion exercise for each of these other components as a tool within physical therapy. And it's why I prescribe it and am biased towards it. If you look at what I give people, it's almost strictly patient education and exercise. But I would also say that if there were a pill that could do all of the things that I just raved about exercise doing with no nasty side effects, I would also be promoting that if within my scope, right? So I think it's just about trying to be as unbiased as possible in that regard. And when you look at the research and how potent it is for pain relief, I think one of the important things to do is look at more chronic things. So Jill Hayden's Cochrane meta-analysis is a great example of this, and it showed, I think, 15% pain reduction, right? When you look at all these different studies, it's typically 1 to 2 out of 10 on the numeric pain rating scale that you can get a reduction from after like 2 to 3 months. And I prefer to look at the chronic pain stuff because we're so bad at controlling for natural history and regression to the mean with these RCTs that we're analyzing, that it's important to look at chronic pain to be a bit more controlled and to take care of some of these non-specific effects, because with chronic pain, you're dealing with less natural history resolving things, I would argue.
Yeah, if someone's experiencing 10 years of chronic low back pain, that's not going to have a favorable prognosis within a 6-week time point from a rehab standpoint. Your next section is just called Beyond Biomechanics. Can you elaborate on the often kind of narrative or strong perspective of there has to be certain positional biomechanical things for an exercise from a pain perspective?
There's some nuance here to where I, in clinic, do make biomechanical changes to things. I modify range of motion and load to be tolerable, but that's about it. So, and I try not to hyperfixate on exercise technique. There's recent papers coming out about how exercise technique doesn't necessarily matter all too much for injury risk, right? And what I would argue is that the common denominator is more load than anything. And load can be modified with range of motion and the actual weight that you're pulling or pushing or however you're doing the movement, right? So the research doesn't seem to suggest that the biomechanics typically matter all too much. And even if you look at like scapular dyskinesia, the shoulder can be less painful whether you change the kinematics of the exercise or not. When you look at chronic low back pain, why does everything seem to work regardless of the exercise pretty well at getting a minor reduction in pain relief? There are certain limitations to the research, and I will say I do believe that symptom modification is a great way of using biomechanics, whether that be to tell someone that as they're sitting down, try to sit in this way for a short time until your symptoms improve by reducing compression on an irritable tendon. Or if modifying range of motion is the way that keeps them in the gym and still squatting, or switching from a back squat to a front squat, I'm all for that. And I think that's a good way to keep people doing exercise, which I believe is my best tool for pain relief largely.
You had a quote in this section: movement clarity matters, but benefits may arise from factors like self-efficacy, fear, locus of control, and social interaction. And you're referring to benefits in this context of benefits from a improvement in pain perspective. What can you touch on exactly what that conclusion is from? The self-efficacy, the fear, locus of control. What does the research suggest there?
Yeah, so it doesn't necessarily suggest that the biomechanics or the typical traditional biomedical theories are what's explaining the reduction in pain. Whenever we look at these mediating factors, it's more so tied to biopsychosocial factors. The one of the examples that I used in the paper was the study by Wood and Geronimo that looked at chronic low back pain with Pilates, which is one of the best researched treatments that we have in movement and exercise, right? Especially for chronic low back pain. And they found that 20 to 30% of the pain relief was explained or was mediated by pain catastrophizing and kinesiophobia, not strength necessarily, right? And then you look at the NEOA meta-analysis that found that only 2% of the pain relief that was found in prior research was explained by knee extensor strength. So you see these things that start to make you question your biases. And what I will say, an important caveat to the mediation analysis study, is that the study included is not set up for mediation analysis. So that's a major limitation. And you can't necessarily say that it temporally, the kinesiophobia the reduction in kinesiophobia happened before the reduction in pain, right? it's possible that those things coincided a bit more because pain relief made them less fearful and they catastrophized less as they had less pain, right? That's also logical to me, I would say. And I think, again, that then gets down to the suggestions at the end for future research, right? One of the scariest things when you start to think about the grand scheme of all this is that we need better research to really answer these questions. We can't continue doing things the same way and still seeing A versus B studies.
At the end of this section, I think you raise a few questions that you may not have answers to, but I'm
Yes.
curious for you to riff on it. So this is the last paragraph in the Beyond Biomechanics section, but this raises the question, how nonspecific can exercise be for pain relief? Could biceps curls relieve knee OA pain just as effectively as more targeted exercises? Would a lack of face validity undermine treatment effectiveness, or could broader exercise options make participation more sustainable? This is, 3 or 4 questions within one, but tell me your thoughts.
Yeah, and part of it was just trying to be a little bit cheeky, right? The bicep curl. I mean, I'm curious about that question, but that's not the next study I'm gonna champion for, a bicep curl for knee OA. I do think it's interesting though. It was one of my I have a long list of research ideas, and it is on that list, but it was more just to say something slightly controversial, I would say. I don't want it to seem like I think the pendulum should swing really far in exercise prescription going off that point, because, and it might surprise some people based on the editorial, but what I'll try to explain to my patients is that the treatment that is, my belief is, the treatment that's the best and the worst might be the same thing. The exercise that makes the most logical sense for me to get you out of these symptoms is probably doing the thing that could also flare them up the most. And that's one of the things that I think acknowledging that can help, because sometimes it feels like when patients come in, they're being a bit gaslit almost when they come in and they tell you, I'm in pain, this thing hurts. And then we just say, okay, great, do more of that, right? So I think we need some good sort of guide rails around that and explanation of the logic of why. I would be really interested to see just how far we could go away from the joint of interest, similar to the manual therapy research, where you don't have to apply a specific treatment to that specific area. It can be proximal or distal to that joint and still receive good pain relief. And it is interesting too, because do you then get a litany of more exercises that they might be more willing to do because it's not as painful doing something that isn't necessarily loading that specific joint in that specifically painful way, like I'm telling my patients to do, right? I think it's also interesting to then question, if we get too far away from the joint, does that lack of face validity then undermine everything? And it's then a question of, will my patient even do this? Because if they're not doing it, then nothing works. And that's an important distinction between efficacy and effectiveness, right? We could show, we'll just stick with the bicep curl example. We could show that bicep curls do reduce knee OA pain in research if done under supervision for 8 weeks. But if I'm seeing someone every week or every 2 weeks and I'm relying on them completing their home exercises, and they have no faith that bicep curls are going to be beneficial for their knee OA pain, or that walking is going to be beneficial for their back pain or their neck pain or anything along these lines, then that efficacy is then lost in the translation or the transition to effectiveness, right? They're not doing it, so it can't be effective.
Yeah, I think a lot of that goes to their expectations of what they think is going to be helpful. And if it's completely either invalidating their desires or requests or their expectations for a general heuristic of what treatment should look like for whatever it is, knee OA or low back pain, and you're giving them something completely different. And even if you're wrapping it in a super helpful narrative, you're trying to educate on the value and all of the options that they have, that still may not be enough for them to be consistent with it, like you're saying, and have some of those other, expectation and improvements just because they're kind of bought in. So there probably is some line in the sand, and that's probably a blurry line in the sand and messy and person dependent, but prescribing exercise that is completely removed from that body region and that person doesn't value it, doesn't understand the benefits, isn't open to the idea of like more systemic exercise and movement can have just as beneficial effects compared to these local joint specific activities, then that's a hard sell.
Yeah, definitely. Completely agree.
Let's go into the allure and risk of certainty. You brought this up early in the conversation
Yeah.
as, a young grad, but a lot of clinicians and patients, we both want to feel confident with timelines, with treatments, with why someone's in pain, why someone got injured. I want you to elaborate on this. What is the risk and what is the allure?
Yeah. So I think the allure is that we get into this profession to try to help people. And we see people when they're pretty low. We see people irritated, in pain, in tears, and we want to help them as much as possible. And I feel that pressure. I'm sure everyone feels that pressure. And it's because we get into the profession to help. And it sucks because a lot of times we can't do enough to help people as much as we would like, and I think that's a large portion of burnout. Honestly, we aren't providing antibiotics for a bacterial infection. It's a lot more complicated and less effective than that. I think that it can be difficult to try to explain things to people in a way that is still appealing to them while also being honest at times. I mean, I've told people when early on when I first started working, I went into an elbow tendinopathy an elbow tendinopathy eval, and I thought I was going to get such good buy-in. I thought she was going to love when I told her about the prognosis of the tendinopathy. And then I explained it to her, and she was so upset. She hated the fact that she was going to have to wait months for relief. Based on, or I didn't necessarily say it would definitely be months, obviously, but I said it could take months. For most people, it does take months, and that was one of the more shocking things. So I was like, oh, I thought this was great news, right? I see people all the time that have been having pain for over a decade. So I thought me telling you just a few more months probably would make you feel a lot more comforted, right? And then I think the risk of that is that we're then selling something that doesn't get cashed, right? And then it gets interpreted almost as a lie, and people say the PT didn't work, or they just start losing faith in all these things because they're sold something different. They're not set up for reality. And I think that the honesty is the least that we can do for our patients. I think I'm naturally probably a pretty honest person, I would say. I think most people that know me would say that, maybe too honest sometimes, but I think that it's the least that we can do, giving our professional opinion in the most honest way possible.
Yeah, I agree. It's easier said than done,
Yeah.
especially if you're a student or a young grad where all you've seen from professors, clinical rotation experiences, whatever it is, your coworkers, they're saying things in black and white terms.
Hmm.
They're having such concrete explanations. There's always so much certainty. And then you're maybe hearing things that are the opposite, or you're reading things that are the opposite, that it's super messy and there's a lot of unknowns, that it's hard to shift your own beliefs and your messaging. And it's this fine line that you want to come across as a confident, knowledgeable clinician and provider, and that you have a path forward. However, you are now trying to tackle the idea of there's a lot of unknowns. I don't
Yeah.
know how long this may take. I don't know if this is the only treatment option. There's a ton of other options. How do I intertwine all of these kind of complex things in a conversation that the person can move forward with and we can move forward with? And it's tough. I feel like it's a daily battle that I have as well, especially for these persistent pain cases where it's like they've tried all the things, or they think it's this one thing is the thing they need to get done, or I'm trying to explain the value of movement and exercise and you don't have to do the McGill Big Three or whatever it is, and you have a ton of options. We can experiment. And some people, they just want like a protocol. They want a cookie cutter routine. And sometimes maybe you lean into that and you say, here's what we're going to do. This is our starting point. There's so many other options, but it sounds like you want more of a concrete plan. But trying to like riff on that in real time with each patient is is tough.
Yeah, very tough. And I think one of the things that you mentioned there is the confidence piece is massive, where I don't necessarily even think that the way that I'm explaining things to patients is significantly better than the way that anyone else is explaining things to patients in the way that the patient interprets it necessarily. Like on an aggregate, let's say, what I say I might believe is more evidence based, but I don't think that a lot of patients care. I think that they come in wanting to just hear, oh yeah, you got a weak core, let's do some planks, right? Whatever that may be. And that sounds super appealing to just come to someone and them say, I know exactly what to do for you, right? And then to someone you come into and they're a little bit less certain, even if it's honest, it does not sell the same way to certain people, right? And it's almost like just matching biases. I treat a lot of people in healthcare working at Duke because just the insurance matches up with the Duke system. And I get such good buy-in with all my healthcare providers, I feel like, because they get it. They understand the uncertainty. And I think that they can appreciate the honesty. And there are plenty of people that don't work in healthcare that appreciate that too. And when I mention research or talk about the evidence, I think that I can get good buy-in from them too. But on the flip side, I think there's plenty of people that don't care at all and just want to be told what they need to do to get out of pain now.
Yeah, it's almost like more taxing for both the clinician and the patient, where if you're this clinician that's trying to be this like kind of progressive communicator, you're really trying to tailor the things towards this individual. You know there's a ton of options, you're trying to discuss this. There's all these factors maybe contributing towards their symptoms and all these levers we can pull from a lifestyle standpoint. Stress, sleep management, exercise, etc. Like one that's hard to like neatly and tactfully like describe and explain. And then maybe you're giving them a variety of options of these are all the things we could experiment with. These are the things in your life we may consider like working on. That's way more work for the patient. Now you're kind of putting the onus on them to like decide out of these options of things that may improve some of the intensity of their symptoms versus the clinician just says, let's do this. The patient says, I'll do this. And it's a very clean seeming interaction and relationship. And sometimes I question the clinic I'm currently at. There are some other providers where it is a little bit more of that black and white. And it just seems so much easier. The patients love them. You know, the therapists still have great bedside manner and they're still super likable and all these other things. I'm like, they're still getting, decent outcomes with these people. One, because the patients like the clinician. And I think that's like 90% of it, especially with people dealing with persistent pain and the confidence and trust in that individual. But at the same time, I'm like, I can't ethically or morally provide this black and white explanation because I know that's not true, but it's way more of a headache to like go down this path.
Yeah, for sure. It's funny because some of the patients that come in the maddest and the most disillusioned by PT, I feel like I can actually spin it around and be like, hold up, you might have something that you're saying that's correct, right? Like, I think that a lot of times they'll have these experiences with these more black and white clinicians. And if things are going well, it's all because of the exercise. If things are going bad, it's all because you're not doing your home exercises. And then that's that risk that we're talking about of that certainty. And then they come into us disillusioned by PT. And I think I can actually navigate towards an agreement with the patient a lot of the times, which is interesting as the provider that they're coming to see to be able to do that. But I think that if we're being honest, we can come to navigate and come to agreement with a lot of things with the patients and their experiences if we take a more evidence-based approach to things, I would say.
In this section, you also bring up this idea of, or this term, attentive interaction. Can you touch on that and what the value of that is?
Yeah. So what I was getting at there was you look at a lot of the patient education research and how effective it is for pain relief. And they go in with this, a lot of times, A versus B setup in the RCTs. And they look to compare maybe a more outdated biomedical patient education, and then they'll compare it to pain neuroscience education, a more modern version of it, right? And then there's no difference, right? I remember, I forget what podcast it was on, but I want to say I listened to a podcast with Traeger, and the study that I mentioned in there, he blatantly said, we set this up with the bias to show that the pain neuroscience education worked, and it did not work, right? And we can get into this a little bit later with you'll a lot of the complaints about exercise or the manual therapy studies are that they're not set up to work, right? They're not done right. But anyways, you see that the patient education doesn't necessarily matter, but they still get better. It doesn't matter which one you do, and it's the same thing as the exercise, right? And I think the common denominator there that I at least pulled on was the attentive interaction. You could say it leads to buy-in, placebo, feeling cared for. I was thinking today, I've literally had a patient who I just spoke with. I did not do a single exercise with. 20 to 30 minutes of discussing probably a lot of behavior change and home exercise program updates based on what she was telling me. And then before she left, she said that she always feels better leaving. Even today, she felt so much better. And all we did was talk, and like I cared, and like I was gonna do something about her symptoms, I would say, but I didn't physically do anything with her.
Yeah, I think there's a pressure that clinicians feel if, let's say, they're treating someone for 30 minutes or 45 minutes if they're lucky, or 60, that they have to fit in all of the exercises that are going to be the thing that's going to push them forward for their chronic back pain or their persistent neck pain or their knee OA, whatever it is. But having that presence of truly listening, asking good questions, caring about the individual, and if that dominates some of these sessions, or talking through ways to navigate their home environment, or building out a home exercise routine, or whatever it is, like you may not even do anything during an exercise session, and maybe from a insurance standpoint that's hard to quote unquote justify, but that may be the more meaningful thing for the patient and for that interaction as a whole. Then I got to rush this conversation. Let's get this over in a few minutes. Let's fill out, 30 minutes plus of 20 different exercises. I don't think that's maybe helpful either.
For sure. I completely agree. And my rebuttal to I got to fit everything in would be, how often are you seeing the person, right? Like if you're seeing them once a week, what does it really matter what 10 minutes of exercise is going to do there, right? Like what matters is what they're doing the other majority of the week, or the other majority of the 2 weeks in between sessions, right? So dial in a good home exercise program, I would say above all else, honestly, for a lot of frequencies for patient returns.
Yeah, I think about that often where there's only 10, 15 minutes left in the session. It's like, all right, how much are we realistically going to get done? And I'm seeing this person in 2 weeks. Let's finish this conversation, maybe wrap things up a little bit earlier, or just do more communication and talking than trying to fit in like 3 rounds of goblet squats that isn't pushing a physiological change. Yeah, so I totally agree. Towards the end of the paper, you have this implications moving forward and some general recommendations for both clinicians and researchers. Let's start for the clinicians. What are some of your recommendations?
So my main suggestions and recommendations for clinicians would be, one, acknowledging that we don't have to pick a very specific exercise, right? We have so much variety in what we can choose. And I think that should be used to your benefit. If we know that most people aren't hitting physical activity guidelines, and we know how important exercise is for people, not just for pain relief, but for all these other factors, why not pick something meaningful and manageable for people? Not only that, with the exercise selection, but the dosage of it. If someone cannot tolerate 2 minutes of walking and they can only do 5 sit-to-stands, let's not schedule this hellacious home exercise program for them, right? Like, let's make it something that they can do long term. If one of the big things that I discuss with people at my discharge appointment is that they don't have to continue doing everything the way that I told them. If anything, I would prefer them to cut back on it. If the options are, I'm burnt out and want to do nothing, or let's just cut back on this and do 1 or 2 exercises consistently for years to come, right? Because if we're PTs and we're saying that exercise is important for lifespan and health span and all these things. What they did 6 years ago for 6 weeks in PT is not important for that. What they do on a consistent basis is. So I think that's one of the biggest things at discharge that could even be actionable for PTs is figuring out what is manageable and what is meaningful for the person long term as well. And that might be completely different than what got them to the point of discharge, right? But maybe just a walking routine for someone for low back pain prevention, right? Even if you had two other exercises throughout the entire time, if they're not the kind of person that's going to want to do a crazy exercise routine, don't make it seem like that's their only option or nothing. And then the other thing was just explaining exercise with humility. I think that we should be more okay with accepting when we don't exactly know why something works. And I admit it all the time. I'll just say the research isn't quite sure yet. And I can give a few reasons. I might list one biological reason, one psychological reason, and one social reason why exercise might help with pain relief. But I always have the caveat that we aren't quite sure yet. I don't think we have to force this narrative that it's strength when we have essentially no evidence that it is strength.
Yeah, I hear you. I totally agree. The way that I've come about framing it to patients with building out either a routine in the clinic or at home or a long-term plan is trying to discuss to them, hey, you've had persistent low back pain for 5, 10 years. Our understanding at the moment in the research is there's a lot of options to help manage some of the intensity of your symptoms. None of them are inherently special. Movement generally is a good thing, but we have a wider array of what that looks like. And what I want to find out during our time working together and for you long term are things that you have access to, things that you generally enjoy, things that you've done before that maybe you want to return back to. And that gives us a lot of wiggle room. And giving that to patients, sometimes it is challenging because, like we talked about earlier, they want just a plan. But a lot of times that plan is boring as fuck if you just map it out, and they don't do it long term. So it's trying to discuss to them, what do you want to get back to? What are movements that you like? Do you have access to a gym? Do you have access to anything at the house? Do you just want to walk? Like whatever it is. And I think that gives creativity to us as clinicians. So it's not super cookie cutter and it's more interactive. And it should hopefully be more salient and realistic for the patient and enjoyable for the patient long term.
So I'll even have patients that come in and from the get-go with their subjective, it's clear that they just want these more classic traditional PT exercises. They want the planks, they want the McGill Big Three, they want these things to strengthen their core. And I'll still go through my spiel with them, but then at the end of it, I'll give them the option and I'll say, is there anything that you've done previously that really resonated with you that you would like to get back into? Is there anything that you do right now that you'd like to do a little bit more of? Or would you just like me to give you some exercises that I think are staples for me as a physical therapist, or that could really just help strengthen your core muscles? And then a lot of times they'll just say, let's strengthen my core muscles. And that's all right. Again, it goes back to the idea that we have options. I'm not saying you can't do a McGill Big Three. I'm just saying I hope that the narrative behind it is slightly different.
Yeah, I've come to have a little bit more openness to, if someone's asking, like a lot of my remote E3 clients, but even patients in person, they're just asking for something that I think is such a complete waste of time. Like they just want a hip mobility routine or something that I don't think is necessary or going to move the needle forward for their specific case. And yeah, I could ask them, well, what makes you interested about receiving that? Or what do you think that's going to do? And sometimes I do that depending on the scenario, but a lot of times I'm like, yeah, sure. And it's like, that is something that they're requesting. It's generally not going to be harmful. If anything, it's just more general movement. It may make them feel better temporarily. I now have a little bit more comfortability of the things that either has been deeply ingrained for them. They want these specific routines, or they want these specific stretches, or a mapping out of what that looks like. In addition to the things that I think maybe are a little bit more valuable, I'm fully on board. And I rarely have pushback there.
For sure. I've tried to get better at being more accepting of things that don't necessarily fit my bias.
And you mentioned this early on, but really this topic is about pain and minimizing and managing pain. This isn't about major physiological tissue-based changes that we're looking for from a postoperative standpoint, or a long-term tissue capacity for those cases, there's a lot more specificity that may be valuable, even though there still may be a broad array of exercises, but we may have specific parameters that we want to be more controlled within, and that we want to be more progressive in nature, and that we have these more true specific things that we're trying to improve. That is different than the conversation we're having now from a pain perspective. And I think that's important to kind of circle back to, and not have the audience think that we think any type of exercise or movement is warranted in all circumstances. But from a pain perspective, there's way more options, and there should be a little bit more humility as to what is or is not occurring, as to why someone may experience benefits with exercise or movement and symptom relief.
For sure. And it might be a surprise, but the way that I dose the vast majority of my exercises is to something like 1 to 3 RIR or a 2 out of 10 pain increase max. So it's not like I'm trying to just say, you can do whatever. I'm still saying, okay, we don't have a ton of specificity that's required, even for maybe the dosage of the exercise, but I might as well kill 2 birds with 1 stone and get you stronger or get you more muscle mass, right? So I think you can still exercise people hard and still appreciate the fact that it might not be all too different for pain relief, but at least I'm getting them stronger, and at least I'm getting them bigger muscles, right?
Yeah, I agree. I think you mentioned earlier, like I think the physical activity guidelines you brought up with, all right, if you want some guidance as a patient, you're asking for it. Well, then I'm going to bring up, here are some really minimum guidelines on cardiovascular or cardiorespiratory timelines or duration throughout a week. Here are some minimums from a resistance training 2 times per week. And within that, if we hit those minimums, that's amazing. You're doing more than most people. And we still have a lot of flexibility within those kind of 2 primary goals. The transition to the recommendations for researchers, what did you say there?
Yeah. So my biggest thing there is we've gotten to the point with the research where, as a collective, or at least within my bubble, everyone's starting to get a little bit sick of the line of research historically, where it's A versus B or A and B versus C, right? Like, and they're not really looking at mediating factors. They're not looking at moderating factors. They're not taking the attention to detail that it seems like we have to really come up with new, interesting answers that we're now left asking. And I think I think, at least based on some of the pre-registrations that I've seen, there's some research groups that are starting to do this. My main concern there is it how concerted of an effort across the globe does this have to be, right? It's tough to design an RCT with enough people to have an active group, a placebo-controlled group, and a no treatment group. But doing stuff like that is how we'll get the best answers. And I think just continuing to refine what we would consider the sort of the floor for a good RCT. If you can't get enough people to ask the question the right way, I wouldn't even ask it in that way yet, right? I think we need to be a little bit stricter with when we start trials, even, and with the questions that we're asking. We need to collect more data from more people in ways that are going to start to answer questions that we're now popping up with.
Switching topics, well, not really, but outside of the researcher, going back to the conversations with yourself and patients, you alluded to the idea or the fact that you heavily lean on exercise and movement and education, because from a pain perspective, we know that there's other things that can potentially be helpful for managing symptoms or provide some transient relief. What is your explanation if a patient asks, why aren't we doing XYZ modality, or if other clinicians in the clinic are doing it and the patients are asking, how do you navigate some of those? If you know that the effects for exercise are modest from a pain perspective, why is that the thing you lean more heavily towards? And what is your explanation to patients as to why you may not be doing all the other 100 things you could do?
Yeah. I typically probably explain it as killing multiple birds with 1 stone, and that by doing exercise, we're getting all these different attributes if we do them long enough, right? The caveat to, oh, we're getting you stronger and living longer and all these things, like I alluded to earlier, is you got to do it long enough for that to happen. 6 weeks of PT is a drop in the bucket for living longer in terms of how much leg strength you acquire to then reduce your fall risk, right? That is 6 weeks is barely enough to see statistical significance in strength. So there are caveats there, but I just explained my biases essentially and why I still am biased towards exercise. It's cheap, it's effective for a lot of different things. It's something you can do on your own. And I think that I can explain to you how to do it on your own in a safe, reliable way. And if we work around your preferences enough, hopefully we can figure out how to do this long term.
Yeah, I have had numerous conversations with patients where they're seeing. I have a case right now that I'm thinking of. This individual, she's in the military, and she's seeing a military physical therapist. She's going to the chiropractor on base. She's received literally every treatment possible, and she's coming to me as her kind of second physical therapist because she wants other options. And during that initial examination or conversation, the first time we were chatting, I explained to her, listen, you've had persistent pain for 10 plus years. You've tried all the things. It sounds like a lot of these provide really short-term pain relief, which is awesome. I have no issue with you continuing to do those. However, if you're coming to another physical therapist, i.e., myself, to find another intervention that does that, I don't know how beneficial that is for your time. And I can't confidently say that it's going to be any better than any of the things you're already doing. However, it sounds like you haven't fully returned back to any type of structured resistance training that you used to really enjoy doing that you're nervous about returning back to. Again, I don't think this is going to be the cure all for your symptoms, but I think the value that I can provide and the interaction that we can have together may be better spent working on mapping out and experimenting with and practicing exercises in the clinic that you feel safe doing and that we can build out for a home routine or for a gym routine for you long term. And to your point, it's kind of acknowledging my bias of like, even if she wasn't already receiving all of those other treatments, I probably wouldn't do those. And it's totally fine if that person does want to receive all those, or they're not seeing another provider, but they realize that I would lean more towards a movement option from a rehab standpoint, and they just want to get dry needled. Go see someone else. That's totally fine. So I think it's also acknowledging as a clinician, you're not going to quote unquote win everyone over. You're not going to be liked by every patient, and you're not going to quote unquote fix or cure every patient. And you have obviously biases. Every clinician does. You're trying your best to help as many patients as you can and provide the evidence and the best quality care. But you can also acknowledge that these are the things that I lean towards that I think are helpful. Here are some things that I'm open to treating and performing, but I can have a network of other providers or other clinicians that patients can go to, or I will refer them to, or patients can go see. And that's totally fine because it's not the things that I think are the most valuable or that I don't feel the most comfortable performing.
Yeah. And then again, it just comes back to just being honest, right? That's all you're doing.
Anything else, Justin, with this editorial that you wanted to touch on or this topic as a whole before we wrap things up?
Yeah. So I think one of the biggest rebuttals that people might have to this paper, and you see similar things with the manual therapy research, is that they're claiming that it's underdosed or it's not the right exercise prescription. And what I would say to that is, even if it were the case that there is to be improvement with improved exercise prescription, I find it highly unlikely that there will be such a large jump in effectiveness, considering how consistently modest the exercise's analgesic effect has been shown to be. Not only that, but I don't necessarily think there's any evidence to even back that point up that it's underdosed. I can look at the exercises in these programs and say, I would not do it like that at all. But I would also expect to be a clear link between pain improvement and strength improvements if the underdosing was explaining the modest pain relief. I would also expect an impressive dose response relationship, which there is not. I would also expect maybe painful exercises to be a little bit better or significantly better than the non-painful exercises, and there's mixed results there. So And it's not to say that I don't try to improve people's strength or think that there isn't an optimal dose for their pain presentation and that I don't allow for pain with exercise. All these things can be true, but then when you look at the aggregate of how people respond, it isn't some slam dunk by any means for exercise. And I certainly don't have faith that we'll somehow go from what we're currently seeing to large effect size in favor of better written exercises, right? So I don't necessarily think that it's the most valid argument against it. And I also think that people have an automatic bias to think any improvement is due to specific effects of their treatment, while any non-response, like I said earlier, is due to the home exercise program participation being poor. I think that a lot of people could also benefit from taking an approach from research of hypothesis testing, where in research you look to reject the null hypothesis. So, because of this cautious perspective, taking the default of the null hypothesis until suggested otherwise, you can't necessarily just say you think X, Y, or Z is wrong because of some theory that you have, right? It should not overtake true human clinically relevant outcomes. My take is not that evidence can't evolve over time, to which I would then update my beliefs, but it's to say we can't try to poke holes in research with just thinking about things in theory and having plausible explanations for why the research didn't pan out to fit your bias. And I think it would be a lot better if people first took the outlook of what does the research actually suggest for outcomes, and then try to explain it mechanistically around that, instead of trying to explain mechanistically why something will actually improve pain. And I think that's largely why we've gotten to this point too, because people come at it from a perspective of they have a logical, plausible theory of why exercise might work. Oh, it increases blood flow. Oh, it gets you stronger. And then they look at the actual outcomes and it's not there, right? So yeah, I think that having a slightly more null hypothesis testing perspective could be beneficial for clinical life. And I think Eric Miera brings this up too in one of his Con Ed courses, right? So that would be a good place to look at for an even better explanation of that, right?
I appreciate you coming on. I'm excited for, you're only a year and a half out from graduating and you've already published multiple papers. I'm very excited to see what things look like for you down the road. Again, if people want to read this, they can click the link. And then if they can't open it, I'm sure Justin would be happy to send it over. So I'll link your information and contact info as well for people to reach out. We'll call it there. Thanks again, Justin.